Hello, my name is Dawn Matz, and I'm here to present to you my DNP scholarly project on early mobilization using the ERAS protocol. So ERAS stands for Enhanced Recovery After Surgery. ERAS protocol was established in the 1990s by the ERAS Study Group, which later became known as the ERAS Society. This protocol aims to promote a quick return to normal function after surgery. The main focus of this project will be on the post-operative portion of the ERAS protocol on early mobilization. This is a national guideline that strongly recommends patients be up on the day of surgery. However, this protocol does not specify how soon after surgery the patient should be up and what a mobility plan should look like. So here's the abstract portion of my project. The purpose or the aims of this project is to determine if implementing a structured mobility plan based on the ERAS protocol would decrease the postoperative length of hospital stay for open and laparoscopic abdominal surgical patients. The background includes the ERAS protocol, which safely speeds up patient recovery after surgery in the perioperative, intraoperative, and postoperative periods. The ERAS protocol is a national guideline strongly recommending patients be up and mobilizing on the day of surgery. Still, there is limited data on how many hours after surgery the patient should be up and what a mobility plan should look like. The scholarly project is a quasi-experimental design using a comparison study with pre- and post-intervention data to evaluate if early mobilization with a structured mobility plan using the ERAS protocol would decrease the postoperative hospital length of stay. The following was tracked for the post-intervention data: procedure type, open or laparoscopic, patient education received, presence of proper mobility documentation, how many hours the patient was first up after surgery, and the length of stay. There happened to be no significant difference in the length of stay between pre- and post-intervention for open and laparoscopic abdominal procedures. There was a significant difference in the length of stay between open and lap procedure groups, the pre-intervention open versus lap, and the post-intervention open versus lap, with the p-value less than 0.001. In conclusion, although there was no significant difference in the length of stay between pre- and post-intervention, it was discovered that the open abdominal surgical patients benefited from the early mobilization plan more than the lap group. So the mobility practice was reviewed at the hospital where this project took place, and the patients were not mobilizing until postoperative day 1 or when physical therapy got them up on day 1. The ERAS protocol fails to specify a target time for patients to be up on post-op day 0 and what a mobility plan should look like. Current literature states that early mobilization as soon as 3 to 4 hours after surgery is best practice. Resources have shown that the ERAS protocol can reduce the length of stay by an average of 2.35 days and healthcare costs by an average of $639.06 per patient. The following is the PICO question. In hospitalized adult open and laparoscopic abdominal surgical patients, how does early mobilization using the ERAS protocol compared to current practice reduce the length of postoperative hospital stay? So here are the specific aims and goals of the project and the intervention that was performed. So the aim of this project, as stated before, was to introduce a structured mobility plan based on the ERAS protocol to hopefully decrease the postoperative hospital length of stay for open and laparoscopic abdominal surgical patients. The intervention included implementing a structured mobility plan, having patients get up within a 4-hour window after surgery, and includes patient and staff education. So this slide will discuss the methods of this project. This project was approved by Hospital Administration and Maryville University's Institutional Review Board. The hospital does not have an IRB. The study was completed on a 40-bed post-op floor in a 470-bed hospital in Memphis, Tennessee. Education was performed on the mobility plan, the goal for patients to be up within 4 hours after surgery, a patient education sheets, mobility documentation, and the mobility assessment tool. Patients also received mobility education. The patients were assigned numbers, no names or other identifying information was used, and there was no conflict of interest. All pre-intervention data was collected retrospectively from previously documented data in the EMR system. After implementation of the intervention, which was the mobility plan, data was again collected to compare to the pre-intervention data. Length of stay was the primary outcome measure. The length of stay in the pre-intervention group ranged from 0.8 to 55.7 days and 0.6 to 12.3 days in the post-op period, or post-intervention group. The validity and reliability of the length of stay depends on whether employees inputted the appropriate times of admissions and discharges. The mobility assessment tool was used for those patients who were more difficult to ambulate. The MAT is a nurse-driven bedside assessment of the patient's mobility status and involves a 4-step task list to identify patient's mobility level. The MAT is estimated to have an 81% validity and 93% reliability in assessing a patient's mobility status at the bedside. Another tool used in the project was structured observation. Structured observation records observations in a specific place, time, and where the participants are during the standardized process. Observations in this study were made ensuring patients were mobilized within the 4-hour window. Further observations were made to ensure patients received mobility education and proper mobility documentation was completed. The validity and reliability of structured observation depend on whether the employees accurately documented the time to the unit and the first time up after surgery. Methods to ensure data quality were followed. The study's primary outcome measure was the length of stay and was evaluated by retrospective data collection from the hospital's EMR system. The following information was gathered for pre-intervention data: data procedure type, open versus lap, mobilization documentation present, and length of stay. Procedure type was collected by reviewing the post-operative note entered by the surgeon and was recorded as 1 for open and 2 for lap. Mobilization documentation was recorded as 1 for yes, appropriate documentation present, and 2 for no. Length of stay is automatically calculated in Cerner for all patients and was measured in days. After implementing the mobility plan, another data collection process began for the post-intervention data. The following information was gathered for post-intervention data: data procedure type, open versus lap, patient education received, proper mobility documentation, how many hours the patient was first up after surgery, and length of stay. Again, procedure type was collected by reviewing the postoperative note entered by the surgeon and was recorded as 1 for open and 2 for lap. To ensure patient education was completed, the researcher, me, would meet with the nurse receiving the patient from surgery and remind the nurse to give the education sheet to the patient. Education received was recorded as 1 for yes and 2 for no. No charts were accepted in the study if no patient education was completed. Mobility documentation was reviewed in Cerner charting system used by the hospital. The presence of proper mobility documentation was recorded as 1 for yes and 2 for no. The time to the unit and time the patient was first up after surgery was collected, and only charts where patients were up within the 4-hour window were included in the study. The time patient was first up was recorded in hours and minutes, and again, the length of stay is automatically calculated in Cerner and was measured in days. So in this slide, we'll review the results of the study. The intervention included a structured mobility plan based on the ERAS protocol. The plan included required education for hospital staff and when to use physical therapy. Hospitalization guidelines for this plan include the following: 1, review provider activity order, assess patient's pre-hospitalization mobility status. RNs are to complete the bedside mobility assessment using the mobility assessment tool when the patient is unsafe to mobilize after surgery. 4, CNAs and mobility techs can progress patient mobility at the direction of the RN. And number 5, patients must get up with assistance with hospital staff the first time up after surgery. If the patient's mobility assessment is independent, then they may walk in the hall unassisted or with family. Number 6, walkers and gait belts should be provided on the unit for patient mobility assistance and safety. Number 7, postoperative abdominal surgical patients should mobilize within 4 hours after surgery if the patient is alert and safe to ambulate. Patients should be walking in the halls 3 to 5 times a day. Number 8, document ambulation date, time, patient first up after surgery, activity status, ambulation time, distance, devices used, and the effort and response of the patient. A retrospective chart review was performed for pre-intervention data with charts dated from November 2022 to February 2023. The pre-intervention data included current mobilization practices. The data collection for pre-intervention included date of procedure, procedure type, lap versus open, presence of mobilization documentation, and length of stay. After the implementation of the mobility plan between February 2023 and April 2023, post-intervention data was collected. The post-intervention data included the date of procedure, procedure type, open versus lap, patient education received, presence of proper mobility documentation, how many hours the patient was first up after surgery, and length of stay. Initially, I only wanted to include open abdominal surgical patients for the study, but after the initial retrospective chart review, it was clear that the hospital did not perform enough open procedures in an acceptable time period to collect the number of charts needed for the study. Therefore, open and laparoscopic procedures were included in the study, 26 open and 27 laparoscopic for both pre- and post-intervention groups. No missing data were identified during the data collection process. No association between outcomes, interventions, or contextual elements was observed, as this was a retrospective review of previously recorded data. Knowledge was shared on the ERAS protocol, a national guideline, and how this helps the patients in the hospital. The guiding coalition for this project included the RN, CNAs, mobility technician, nursing manager, nursing director, chief nursing officer, and the IRB. Staff education was completed on the mobility plan, the goal for the patients to be up within 4 hours after surgery, mobility documentation, patient education sheets, and the mobility assessment tool. The vision for this project was to empower nurses to facilitate early mobilization for their patients to promote improved quality of care and patient-centered care. So this slide will review the analysis of the data. Data was analyzed using SPSS statistical software with the assistance of Maryville University statistician. This project is a quasi-experimental quantitative research design using pre- and post-intervention to determine if the length of stay was reduced with a structured mobility plan. The study included a sample size of 106 participants. There were 53 pre-intervention and 53 post-intervention charts included in the study. There were 26 open and 27 laparoscopic procedures included for both the pre- and post-intervention groups, to total the 53 charts needed for pre- and post-intervention. The inclusion criteria includes participants over the age of 18. Both male and female were included, open and lap abdominal surgical procedures, patient mobility education completed, patient able to physically mobilize safely after surgery, and EMR documentation of mobilization within the 4-hour window. Exclusion criteria included patients under the age of 18 years of age, no documentation of mobilization attempts or time up after surgery, patients who did not receive mobility education, patients whose baseline mobility status is poor or were unable to safely mobilize after surgery, and prisoners. So in this study, the pre- and post-intervention groups are distinct, therefore giving a higher probability to detect a statistical significance. The study included a sample size of 106 to provide an effect of 0.5 with a significance of 0.05 and a power of 0.8. The effect size of 0.5 showed a minimum sample size of 106 was needed to complete the study to reach a power of 80% to detect a statistical difference. A Mann-Whitney test was run for pre-intervention, post, and post-intervention for all procedures, open and lap. There was no statistical difference in the length of stay between the pre- and post-intervention for all procedures. The p-value of 0.728 is greater than the level of significance of 0.05. Another Mann-Whitney test was run for open versus lap procedures. There was a significant difference in the length of stay between open and lap procedures. P-value was less than 0.001. Another Mann-Whitney test was run for pre-intervention open versus lap. There was a significant difference in the length of stay between the pre- and post-intervention open versus lap, P less than 0.001. Lastly, a Mann-Whitney test was run for post-intervention open versus lap. There was a significant difference in the length of stay between post-intervention open versus lap, p-value less than 0.001. So although there was no significant difference in the length of stay between pre- and post-intervention for all procedures, there was a significant difference in the length of stay between open and lap procedures for the pre- and post-intervention groups. The open abdominal procedure group seemed to benefit better from the early mobilization more than the lap group, with a decrease in length of stay. Patient and staff education on the early mobilization made a difference in adherence to the mobility plan. Staff was educated on the mobility plan, goal for patients to be up within 4 hours after surgery, mobility documentation, patient education sheets, and the mobility assessment tool using handouts, meetings, unit postings, and email distribution. The project strengths include education for the staffs and patients. I was available for questions on the floor, data collection methods, and random selection of patients. The project limitations included barriers to early mobilization and reliability of documentation. Another limitation is that lap procedures had to be included as there were not enough open procedures performed in an adequate time period. This project characterizes generalizability as the result's usefulness can be used in other procedures besides abdominal surgeries. Although abdominal surgical patients were the target population, other patients undergoing surgical procedures would benefit from the patient mobilization education and the mobility plan this project instituted. Also, the floor nurses would benefit from early mobilization education that was presented to the staff during this project. The results can be applied to other non-surgical floors and non-surgical patients. Sustainability in this project is the continued adherence to the mobility plan and integration of this plan into other sectors, such as general medicine and other surgical procedures. Barriers to this project included not enough open procedures performed in a timely period, only one mobility technician was available, and locating appropriate information during the chart reviews. Facilitators included organizational and leadership teams, and the organization's electronic medical record system and informatics team. So this slide will review implications for nursing practice. Instituting this mobility plan into hospital-wide policy will standardize practice and will reduce gaps in care and create consistency. This project shows the need for a hospital policy on early mobilization. Utilizing mobility technicians would ensure patients were mobilized in a timely manner. The mobility plan should be integrated on other floors and used in other procedures. The project results must convince policymakers that the proposed intervention worked and that developing a mobilization policy would be in the hospital and patient's best interest. Continuing education for staff will ensure understanding and promote adherence to the structured mobility plan. The project reinforced education to staff and patients about mobilization to promote the change process. So here are the implications for future research. A longer research period with the structured mobility plan using only open procedures would yield more positive results. Research on the organization and patient barriers to early mobilization would be instrumental in developing a structured mobility plan. Understanding barriers to mobilization will guide providers to tailor a mobilization plan for each patient. The ERAS Society should recommend a specified time period that patients should be up after surgery on the day of surgery, and be more detailed about what a mobility plan should look like. So in conclusion, overall, early mobilization is the best practice, and all hospitals on the post-op floor should be doing this. Early mobilization improves all aspects of recovery after surgery. Patients can return to their baseline function quicker with early mobilization. Adhering to a structured mobility plan will ensure proper execution of early mobilization practices. Education for staff and patients will ensure adherence to the mobility plan. Understanding barriers will help the staff tailor a mobilization plan for each patient. A longer research period with open abdominal procedures only will give more insight on the effect of early mobilization has on the length of stay. The ERS Society should recommend a specified time the patient should be up on post-op day 0 and what a mobility plan should look like. The next 2 slides are my references, and then the last slide is my contact information. If you have any questions, please reach out, and thank you for listening.